And hello, we are live and awesome. All my students are already here. So, Henny, Jen, Nick, Joey, awesome. Addison, Jalen, beautiful. Thank you so much. Everyone check in. Let me jot down everyone's name and then we will rock and roll. Oh, Anna, I didn't ask, how do you say your last name? Guimbarda. Awesome. And we are figuring out the little clicking issue. I'm not sure what that is, but we'll figure it out. Or Anna will just talk a lot more than me if it's on my end. All right, so let's rock and roll. Everybody's just about here. Jason, Alex, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We'll give it another minute. And wow, yeah, that's like my echo. And it did it on both microphones, so I'm not sure. It might be a browser thing. It sounds like a very deliberate type, right? Like somebody is typing something and then hitting enter. Kaylin, Jason, thank you. Lexi, hello. Yeah, I muted myself and it kind of stopped. So, all right, well, hopefully this will work and I'll figure it out while maybe you're talking one of these times. So let's rock and roll. I think enough people are here. So today in Careers and Exercise Science on Wednesday, October 14th, we're talking with Occupational Therapist Anna Guimbarda from Athletico in South City. And so we were fortunate to have Taylor Stride from Brentwood Athletico the other day. And so, yeah. And so let's rock and roll. So looking at your sheet, and I just asked you a little bit about this. The letters behind your name, your credentials, it says MOT. So tell us a little bit about just what MOT means exactly and a little bit maybe where you went to school.
So I have my master's in therapy. That's what I went to Maryville. I'm from St. Wanted to find close to program. So that means I through the master's. My third year in school, that's when I became kind of a grad student. That's how they rolled the program out. So it was pretty expedited, challenging at times because I took upwards of 18 credit hours a semester. And I also was in the honors program. I did that at the beginning. I was like, oh, I'm going to take some honors classes. Quickly realized that was filling my plate up a lot. But so sometimes I was upwards of like 18 to 21 credit hours a semester. So, but yeah, so that's what MOT is. And then my second bit of my credentials is OTR/L. That means I'm an occupational therapist registered and licensed in Missouri. I also had my Illinois license for 2 years because I did float for the company for 2 years. And that means I covered Edwardsville, Collinsville, Alton. So basically hopped around like 16 different clinics for Athletico.
So the difference between being registered and being licensed, can you speak to that a little bit?
So the registered is through the National Board Certification of Occupational Therapy. And that allows you to get some continuing ed through that particular board. The license is your actual license. So some people they can treat with just the license. You do need that to practice. I have a professor at Maryville. He's actually the director of the program that just went straight to the license. He didn't get the register. He didn't agree with something that the board of occupational therapy was doing at the time or something. So he just goes OTL. So, but I chose to, and you have to pay a renewal fee every 2 years for NBCOT to give you that R. So
that doesn't change like insurance reimbursement or anything like that, or that sort of thing. Wow. So my microphone is apparently it's my side, whatever's causing a little clicking and typing. So, but I think I can mute my mic each time I ask you a little something. So going into occupational therapy, was there something that in college and high school was an experience that you had that you just decided this was something you wanted to do as far as helping people, enjoying studying the body?
So I, like probably a lot of you exercise science students, wanted to help people from the get-go. I just found that I'm somebody who couldn't sit behind a desk and count numbers all day, or work in an office space. So basically my history was in sports. I played softball competitively year round up until 19, when I tore both labrums and I couldn't pursue past that point, even though I was going to be recruited by SLU, I think, at the time. And then they had a coaching change. It was just a hot mess, but ended up working in my favor because I was a program of my choice and be a little bit less stressed. So, but yeah, I at that point, with my fair share of physical therapy, as I'm sure, some of you may have had, liking the environment and liking my therapists a lot, and communicating with them and kind of seeing like, hey, can I just like come observe for a day and kind of just see what it's like. And so yeah, my mom, dad, and I sat down one day, coming up to my junior year of high schools, discussing like what I was thinking in terms of, going to school, what I was feeling. And I knew that I wanted to stay local, like I said. So my mom had known that my interest in therapy, physical therapy at least, and I kind of had my mind made up that that's what I wanted to do. But at that point, we were kind of, unsure of the best programs in the area. So she brought to my attention Maryville. It wasn't even on my radar. Turned out to be a perfect fit. Not only that, but scholarship money was a huge thing too. Anything that you can get is helpful, right? So we ended up going there, visiting, loved the program, loved the faculty, and it was the perfect fit. And that's where I ended up, and I couldn't be happier with the choice that I made. You have different specialties in occupational therapy. I started out kind of wanting to do pediatrics, quickly realized in the program that was not for me, but the majority of my class chose that route. So, and I'm the only one that chose hand therapy in the group. So
that's your specialty, is hand therapy? Most of your patients, all of your patients?
So I specialize as a hand therapist, or I'm soon to sit for the certified hand therapist board exam coming in the next few years, but it's an extensive test you have to study for and everything. But I treat patients who have upper extremity injuries, shoulder, wrist, elbow, hand, and I see trauma, I see carpal tunnel, I see osteoarthritis, all that stuff that intimidated my classmates very much so. But I love anatomy, so I love seeing x-rays, I love seeing injuries, I love helping people with that traumatic event too, because it's more, it's physical, but it's also the mental side that I enjoy too.
I'm going to try this for a couple questions while I mess with my microphone.
Okay. So yes, so I frequently have everything, proximal wise, shoulder, scapula, all the way down to the fingertips. That's what I'm treating. And a lot of times with shoulder issues, scapular issues, stems from the neck, right? So everything's kind of connected. The whole brachial plexus, which innervates your whole upper extremity, comes out of your neck from C5 to T1. So basically what I do with my patients is if they come in with a shoulder injury, I'm checking your elbow, I'm checking your hand, I'm checking your neck, I'm checking your posture, everything that plays into it. And it's really fascinating, talking with patients and seeing that light bulb go off of, oh, I've been doing this for years. You're saying that me sitting at a computer is leading to elbow pain. Yeah, it's all connected. So if we can kind of work on ways to like shape your environment, shape how you're actually holding yourself throughout the day, less forward, more upright. That's what I enjoy about the job, is when you see those light bulb moments. So certification by body part. Well, we have numerous programs that you can get extra certifications for. Some of my coworkers have gotten manual therapy certified, which means head to toe physical therapist have specific joint mobilization techniques, soft tissue mobilization, massage, all those specific things. That extra specialty it's a very hard certification, but it's kind of sets you apart, right? So that's the purpose of them. In terms of body part, the hand therapy specialist or the hand therapist certification that I could sit for is extremely extensive. The test, I believe, only has a 49% pass rate the first time. So it's very difficult, but that is, I think that's probably the only one that has a specific like body part associated with it. And then you look into vestibular. We have a therapist here that specializes in concussions, vertigo. There's also dry needling certification, which is kind of using an actual needle like acupuncture style to kind of release trigger points. There's pelvic floor, men's health, women's health, stuff like that. And we're fortunate at most of our locations to have those specialties present. So it's very interesting to hear their input as well after they take the exam and everything on different techniques. And we can refer our patients if that comes up in conversation. Oh, microphone, Dave.
No wonder it was sounding so good. Are these open up for PT and ATs?
Yeah, so the majority of the certifications fall on the PT side in this realm. OTs can certainly become certified in certain things, but mostly it's going to be the certified hand therapy route for us in this specialty. But outside of this, I have friends in pediatrics and everything that become certified in their own specialties as well. I just can't speak to it too much because I don't have personal experience with it. But so at our location, how many PTs do we have? Six. We have 6 PTs here, and we have myself, the one OT, and then we have a certified occupational therapy assistant who's been working with the company for a long time, and he does industrial rehabilitation for work comp patients coming in with pretty extensive therapy background. Coming in to the program after routine therapy with us, then they go over to his side and do more like 4-hour long therapy sessions to get back to what their job requires. So it's pretty neat. He's like a whole jungle gym over there.
Is that what this is here?
That's Larry's fort.
Cool.
Yeah. So he's got, if you can see kind of in that picture, a ladder on either side. He's got an axe there for firemen that come in. He's got a little wall that he built for policemen to jump over, and that little sled there to push.
That's cool. Okay.
But yeah, I actually take my patients over there quite a bit when they're in the higher level strengthening phase, because as an occupational therapist, we stress function and return to occupations, not meaning jobs, meaning like, gardening, lifting things into shelves. And for some of my more active patients, like athletes and stuff, it's fun to kind of incorporate some creative ways to do strengthening rather than just hitting the bands or dumbbells,
Sure, absolutely.
Yeah.
Well, you can talk about yesterday and today, or who's your typical patient? Do you have kind of a specialty? Do you do a lot of post-op, hand therapy?
Yeah. So oddly enough, when I was floating for the company for Athletico for 2 years between the 16 different locations, I saw a lot of hand, wrist, and elbow patients, and most of them were post-operative fractures, dislocations, tendon surgeries. You hear some crazy stories of lacerating tendons via a saw or a kitchen knife. Traumatized me. Remember slicing an avocado? That's for sure.
Yeah.
Those sorts of things are, freak accidents, right? And so I saw patients on the back end of that right after surgery. And strangely enough, I come to this location here, started here last September, for finally kind of stopping floating. I just wanted some more consistency. And now I'm seeing all shoulders. So it fluctuates.
All shoulders?
Yeah. Shoulder pain, scapular dyskinesis amongst athletes. But my general I'd say what I see now is kind of, middle-aged adult with pain persisting for a year, few months, and it's typically an impingement sort of issue with their shoulders. And again, that's stemming from people being at home with COVID, now having to work, in front of the computer, and everything's kind of just very relaxed and forward, and that just puts you anatomically in a bad position for anything that requires overhead or anything like that. You're going to be constant tendonitis up there.
So a lot of overhead athletes. You said scapular dyskinesis.
Yeah, so that it's actually been kind of interesting to get the young athlete in here and kind of see how their scapulas are actually doing compared to their their distal extremity. So they have typically presented to me with winging of their scapula, so they're lifting off their back a little bit. And when I have them do an overhead raise of their arm into abduction or flexion, typically you'll see the scapula kind of flip back fast upon lowering because they have decreased eccentric control of their rotator cuff. So so you'll see the when the arm comes down, you'll just see a little whoop of the scapula at the end, and that's basically kind of where I have the discussion, like, hey, this is what I see. You may not notice it, but it's something that if we strengthen those muscles, yeah, exactly. And if we strengthen those muscles, your serratus anterior, your mid-trap, your lats, we're going to see some progress in your overall shoulder health. So it's kind of a tricky one to guess timeline wise as to, like, how much or how long it'll take therapy wise to address. Sometimes it's more severe than others, but it's also a good discussion to have with your patients too.
We just talked about this in kinesiology, so I thought maybe you could speak to this a little bit. Do you see it more as overuse? Just kind of, I'm a volleyball player, I do a lot of hitting, or do you ever see long thoracic nerve dysfunction? Do you do nerve tests for that?
So we basically, with every shoulder patient I see, I screen for this, and I have not personally seen any long thoracic nerve dysfunction particularly, but if that is ever a question, I always will contact the doctor and kind of, get their 2 cents on. I like to speak to the doctor directly if that's the case. But I would look for atrophy in the muscles innervated by the long thoracic nerve. And, it's a lot of palpation, really feeling deep in there and having them raise their arm to see the contraction there. And a lot of times it's not super severe winging. If there's super severe winging, then you're definitely looking at some long thoracic nerve involvement.
Okay.
That's when I'm calling the doc. If I see, it's typically minimal to moderate winging that I see, but that decreased eccentric control of the rotator cuff is really the indicator for me, like, okay, we need to address this before we move forward. And a lot of times athletes are wanting, they want to lift heavy weight right away, and I have to kind of give the whole spiel of, we're going to be doing stuff that seems really easy, but it's very purposeful. So high reps, very, very low weight. I hardly advance anyone with my shoulders. We have a green or a yellow TheraBand, red, green, blue, black, gray. And that's from easy being yellow to hardest, which means gray. I never advance my shoulders past yellow. I'll just beef up repetitions like crazy. So that's what I firmly believe in that, because you can do heavy lifting when you leave me, but I'm looking at conditioning you. I'm looking at building up strength of the slow twitch fibers more so than the fast twitch.
Yeah, just good movement, good control.
Yeah. Oh, no, I have not. See, I love this. You learn things every day. So this is
we have Dr. Kirsch. We have a student doing a senior thesis project on this. He's an orthopedic surgeon. He looked at impingement problems in shoulders, subacromial compression issues and syndromes. And he created kind of a hanging protocol and just talked about the need for people to hang more. It's an interesting thing. I just thought I'd ask because we have a softball player who's got a bum shoulder, and she wanted to study this. So we're looking into a variety of student athletes, but also staff and faculty. If we can get more staff and faculty involved in our studies, we can do that.
Yeah.
A lot hanging from pull-up bars, hanging from branches and stuff. Yeah, it's pretty interesting as far as what his theory is. He talks about the humeral acromion joint that kind of comes into play when you go into full flexion. It's pretty interesting. And trying to actually
I like that too, because that end range flexion is something that a lot of people struggle with because that's where they're getting their impingement. And I do manual distraction of the glenohumeral joint myself with my patients, and it's really, really hard with my bigger guys. I had a guy that was like 6'7". I'm 5'9" on a good day with my hair, but I trying to get a hold of that arm and distracting. It's it hurts my hands. By the end of the day, I'm like, but that protocol, that sounds pretty cool. I mean, I'm always interested in reading into studies and looking up stuff to kind of get more creative in here. I hate doing the same thing over and over again, so.
It's interesting. He's a surgeon. He using CT scans, he looked at loaded hangs in a supine position. So he basically loaded with a pulley hanging off the table.
Yeah.
He loaded the position, distracted it, and it took a lot of CT and X-rays of that position. So it's pretty interesting read anyway.
Yeah, I'm gonna remember that for later. That's for sure.
Here's a question from a student, Michael.
Oh, that's a really good question, Michael. So yeah, I always tell my patients one of the biggest things with shoulder health is that posture I was talking about. I call it the gorilla posture, right? Because our pecs are so big, they're so quick to gain bulk because everything we do is forward, right? Rarely are we, fully extended and getting, perfectly upright. So a lot of what we do is in flexion in our hands and our elbows. Everything is flexed. So what I tell people is we have to take that in mind. When you look at your shoulder, you're dealing with everything, like I said, back to the scapula. So what I have people do, my gold standards, without looking any further for shoulder health that I give home program wise, we're doing scapular retractions. So sitting up straight, slowly contracting mid-trap rhomboids, bringing the scapula together, hold for 5 seconds, 20 reps of those, like 5 to 6 times a day. It helps break up your workday too when you're in front of the computer. I also look at your serratus. So we're doing protraction of your shoulder. And we're going to be doing that supine with a dumbbell if possible, 1 pound, 2 pounds at most, and just high reps of it. I have stretching patients with posterior capsule tightness do some stretching behind the back with a towel. Kind of gets them a little bit more opened up because a lot of times impingement happens reaching behind your back. But definitely scapular retractions, protraction of the shoulder, supine, serratus punches. Let's see, stretching of your scalenes, even side to side bending stretches. And
we'll do these in class today. I have Michael at 1 o'clock in class in kinesiology.
Yeah. So, stretching your upper trap, on either side, forward is good. Side bending. Because a lot of times these muscles up here, your scalenes, your upper trap, your elevator, they're just fired rock hard on some of my bigger guys, and the pecs too, so tight. So I have my bigger guys, anybody that's demonstrating that rounded shoulder posture, immediately we're going to the door frame, leaning forward, elbows at 90 on either side. You're leaning forward 10 seconds, doing that 10 times to kind of stretch it out here. And it's almost immediate when I have them, dropped you. It's almost immediate when I have them raise their hand after that, or raise their arm, that pain relief. So definitely a lot of stretching in the beginning, a lot of stretching, a lot of strengthening of the mid-trap and rhomboids.
You mentioned this earlier. Do you have something you use or an example?
Yeah. So I use something like this. Oop, where is it? There we go. In hand therapy, spiky ball. So I'm using this for desensitization of scars, getting into the flexors and extensors. I have, patients weight bear through it and kind of roll through the tissue not the most comfortable thing, but we can progress to this. If they can tolerate a tennis ball, then we'll slowly move on to something like this. In terms of a modality, I use ultrasound only intermittently. Some people use it a little bit more frequently than I do. I use it for more, I would say probably a tendonitis of the elbow, so tennis elbow, golfer's elbow. And I do maybe about like 8 minutes of it at most. And then we'll go into some range of motion and some stretching. But definitely heat and ice every session. Everybody starts off 10 minutes of heat. Then we get into some stretching. I do some soft tissue mobilization, get in there, do some joint mobs, and then we're hitting the ground running from there. It gets kind of difficult when I have multiple patients because sometimes I have 4 patients at a time. So it's,
Is it four patients?
Yeah. So we're busier right now. I was not seeing 4 patients at a time before, but it's kind of overlapping, right? So I'll say I have like 1 person at 9, 2 at 9:30, 1 at 10. So it's just kind of a steady flow. But you learn how to do that dance once you get in the swing of things. But so I try to spend at least like 15 to 20 minutes of manual therapy with each of my patients. I think that hands-on is our most skilled practice. So I think a lot of times, unfortunately, insurance doesn't reimburse that much for the manual therapy, but it is my go-to for everybody. I like to have my hands on people and, really making sure that I'm feeling the progress, via palpation or what have you. And I think that a lot of times that's what people, patients coming into, that's what they want. They want to feel that sense of security, like, okay, she's actually feeling a difference. So I must be getting better, or I have this to work on. So I think
Sure.
hands-on is huge. Yeah.
Undergraduate school question.
That's a good question. Yeah. I definitely, with occupational therapy, we were very fortunate. We stress psychology a lot. I could have almost even probably had a minor in psychology. Ab psych was my favorite. But I think a little bit of the business aspect would be huge. A lot of times you come across patients in terms of going back to the psych. You come across patients who, for the longest time, have been dealing with chronic pain, right? And it wears on you mentally. And on my side of things, as an OT, I look at people's engagement in their daily life. What are you doing that's, your hobbies? What's hard for you? What do you want to do? Is there something that you haven't been able to do ever that I can help you work towards? And so, the mental side of it is, I venture to say I almost enjoy that the most, is seeing that progression from I'm scared to do this to I can't believe. I had a patient today that said she was able to brush her teeth for the first time in months without pain, and that's huge. This is somebody that's had osteoarthritis for her whole life. She's dealt with it for a long time. The simple act that we take for granted every day, brushing our teeth, some people haven't been able to do for years because of pain. And to be able to make a difference with something like that, it really, that made my day, just that simple thing. So, it truly is sometimes I honestly have had some sessions that we put everything away and we're talking for 30 to 45 minutes. And those are sometimes patients that you have to take in a separate room. I've had to do that at a separate clinic when I was a float therapist. And sometimes they just need somebody to listen. I think that's a big part of what we're doing, and with your students too, Dave, is you want to help people. So a lot of times helping is physical, but most of the time helping is mental. And I think that's a huge thing in our careers. We get that opportunity that a lot of people don't.
kind of along those same lines.
I'm sorry.
This question along your same lines. You can read it.
Oh, marketing's a big one. Yeah. So as an outpatient clinic, you're obviously competing against some of the big wigs in the therapy world, the hospital-based outpatient clinics, and just getting your name out there in general as a therapist. You want people to say, hey, I want to, when they go to their doctor and they recommend, so-and-so for therapy, say, no, I want to go to Anna in South City for therapy. A big thing that I didn't expect is truly how much you're going to be building a rapport with people. So I have had probably 2 or 3 patients, at least in the past few weeks, that have, my family owns a restaurant on the hill, and it's called Adriana's, and they frequently have come up in conversation, or it's come up in conversation with them that I have that restaurant, and then they go and see my mom, and then they come back and see me. So it's just like, you're constantly having discussions with your patients. At least I do. I'm a talker. And I think that a big thing is building that bond. And then also on the marketing side, another talking point with docs, right? I have a local business here, So if you kind of, charm them a little bit, then they're more likely to say, oh, Lightbulb, I know who's in South City, that one, therapist that has the family restaurant. So it's just stuff like that I think is something that I didn't necessarily expect would be so beneficial in terms of interpersonal skills. But I've been to, like I said, lots of therapy in the past when I was younger, and a lot of my therapists they were kind of more removed. And I think that if I were to have somebody talk to me throughout my session and, like a casual conversation, it would have been a little bit more enjoyable. So hopefully I provide that for people. So I work 40 hours a week. My schedule varies. I have an 11-hour day on Monday. I work 12:30 to 7 on Tuesdays and Thursdays, and I work 7 to around like 2-ish, 2:30 on Wednesdays and Fridays. And I like that schedule because a lot of my friends don't get out early on Fridays, but they also don't work as late as I do some of the nights. So, but I enjoy it. No kids or anything, so I have that luxury. Some of my coworkers have had to change their schedules around with COVID and virtual learning and all that for their kids. So I'm fortunate in that regard. Oh, and we do get holidays. Yeah, we don't work on the weekend.
No.
And we're off on Thanksgiving. We're off on Christmas. We're not off on Christmas Eve, but I think this year Christmas Eve is a Friday. We might get out early, but overall, very good. I get 3 weeks of vacation too, and I'm 26. I'm only 3 years into the degree or the career, so that's pretty good, I think. I haven't used any this past some odd months because I was down to almost like only 2 patients on my case at the beginning of COVID. That was crazy.
Sure. Right.
So 5-year plan, definitely trying to get that certified hand therapy certification. It's a doozy. I just got to bring myself to study. This year was not the year to start it. Too much else going on. I think this is the year for us to take care of mental, and physical health, obviously. So, but yeah, definitely in my 5-year plan, I'd love to build some closer bonds with the docs around here and make a name for myself, in this market at least. And I'd like to kind of, grow, obviously caseload here. It's pretty busy right now, but I'd like to be one of those therapists that consistently has, patients coming back or word of mouth marketing between patients and their friends that come back to me. So. Yeah. So, in my schooling, I did 3 one-week clinicals at different locations. They stress trying different settings. So I had 1 long-term care, 1 at Athletico, which helped set up my big clinical round. We had 2 big ones. The bigger ones are 12 weeks for occupational therapy. It's different for physical therapy, and every school kind of differs, but definitely differences in the clinics. I was fortunate with my 12-week at Athletico to go to our St. Peter's location and then the De Pere location. Our St. Peter's was slammed, like 18 patients a day, and just like working them like crazy. Work comp patients were huge there, Medicare patients. And then on the flip side, the De Pere clinic saw a bunch of walkover splints from the doc's office, which was downstairs in the De Pere hospital. So I got the balance of busy schedule and then slower schedule, but also kind of chaotic because you have to make splints like on the fly. So it was a delicate balance there, but I was fortunate to get that experience. Not everybody has that opportunity. So.
Ask about a few specific courses in Louisville.
A few specific courses that I took. Okay, so some of the basic ones were Intro to Occupational Therapy, Assistive Technology in Occupational Therapy, Kinesiology, Gross Anatomy, Neuroscience. So when we're looking at just the occupational therapy side, the assistive technology is huge because a lot of my my peers in my class, they would eventually encounter that assistive technology when they go into the workforce. So I don't have a ton of that on my side because mine is a biomechanical approach, but a lot of my patients that work, or a lot of my friends that work in with stroke rehab and spinal cord injury, they're using a lot of adaptive equipment and those sort of devices to help people get back to what they're needing to do day to day. And then we also had a splinting course, which was huge. Not every school, hardly any schools actually have a splinting course. We had a full semester of it. And in that course, we learned about modalities. We learned about STEM. We learned about ice. We learned about ice massage, all sorts of thermotherapy. And that was actually cool. We got to go to the, what's it called? Orthopedic Center off of Highway 40, like North Outer 40 or something down in Chesterfield, and actually got to, test on each other. So our instructor was actually a hand therapist at Millikan, and she had her master's degree, I believe, but she'd been working for a long time. So credentials, again, they differ based on generation, but years of experience, I think, trumps everything. So that's the big thing is, somebody with 30 years of experience could have a bachelor's. Obviously, they're more experienced than me who has a master's. So,
Right.
But the big thing is, they didn't talk a ton about relationship building in school, and I think that's something that you kind of learn just in the workforce. But it's so huge. It really is. I mean, you have to get out there and market yourself, especially with clinics popping up, left and right for other companies. And it's truly something that they can't teach, but the interpersonal skills, they kind of, more or less can weed that out via an interview, when they're selecting you to a program. But it's something that I think is absolutely huge. You have to be a people person.
Yeah.
Any advice for undergrads? So don't sell yourself short. Try to get yourself out there and meet some of the faculty if possible, be it virtual or in person if you're fortunate enough. I know this time is kind of crazy, but I think if people see one thing on a screen, they can come up with their own conclusion about like how you are as a person. But I liked the fact that I had an interview with my director of the program, and I actually got to see a few other faculty at the same time of that interview. And I don't know if they do that anymore at Maryville, but it's a big thing, right? Your personality shines through more so than on an application online or what have you. So, and get out there and observe. It's, if you're fortunate right now, I know it's different, like I said, but if you're fortunate to get some observation time, definitely take advantage of that. Even if it's a few hours, if it's something, that you can put on your resume, go for it. Application.
Transcript.
Transcript, yeah. Definitely different in different cities. We are in a saturated area right here for all health professions, but and multi-state licenses unfortunately don't affect it in my realm, at least. But yeah, so for Masters of Occupational Therapy salary range, I've heard as low in this area amongst my peers as $52,000, starting out to one of my friends in a rural area made like 72. So
starting at 70.
Yeah. So but obviously PRN jobs are going to be different, if you're just going in, and not having those benefits or anything, but you're thinking, cost of living is different in different places. But generally that's the range, like 50 to 70, I would say, starting out. I don't see an occupational therapist making less than 50. So this is a big question too. When you're considering schools, at least I can speak to the St. Louis area, right? So I don't know outside of that, but in terms of what you're looking for in a master's program for OT, you have, like you said, research-based, clinical-based. Maryville is known for clinical-based, and I wanted that because I don't have an interest in doing research outside of here. I enjoy reading research and research articles and staying up to date, but I don't want to conduct research personally. So if you were to go that route, WashU, their doctorate program is because they stress the research and the occupational science side of it all. But personally, I wanted to go more clinical based. I want to get more hands-on and have that stressed more. So SLU, WashU, Maryville. Does Missouri State have one?
Edwardsville? Does that say one?
They might. Shoot, I don't know. That's a good question, Dave. I don't know. The ones that I was looking at.
I should know this.
You know this? Yeah, you're quizzing me now. I don't know.
No. I should know this is what I'm saying. It's my job to know this, but
honestly, it is kind of difficult because things are changing so much. One school not too far from here dropped the program that my friend was looking at, and that's how she ended up at Maryville. So, it changes, and it changes how they're doing things. They might do a post-bac program and not have a actual straight through like I did. But I'm gonna have to look that up now. I'm curious. Yeah, ask me anything. I've got some stuff here I can show you.
anything else you want to share, Anna? You say you do have something there?
Yeah, so I just had, so as a hand therapist, we frequently have to make splints, and I was fortunate to get this new material, there we go, OrphiCast. So this is, I frequently have to make splints out of stuff like this, which is a low temperature thermoplastic. So this here, I put in water that's about 165 degrees and melt it down, and it conforms to people's bodies. So if I'm doing a hand, I'll have them kind of rest in a position just like this and kind of just drape it over, and it contours, and then I trim it up. But this stuff, the OrphiCast, is a fabric, and it feels a lot more comfortable on. So I basically just heat it up, wrap it around the thumb, trim it down, attach some Velcro, and then you've got a thumb splint for osteoarthritis.
Nice, very nice.
Like 15 minutes, not even. But it's just simple stuff like that. I love that I'm basically playing adult arts and crafts. So, but you just get to get creative. You know, I make splints for patients daily that are just like exercise splints, and they love it because they have something to take home. You know, something like, let me see if I can fit it on right. Something like this could be used for a sagittal band rupture, but also could be used, I'm having a really hard time with this, bending the PIP joint of the finger. So you have a little blocking. You just get creative, you know. I think that's why I really like this job, is that I'm constantly able to use my basic tools that I have day to day and just get artsy with them and see what my patients are looking for. And I tell my patients we work as a team. So it's not that I know everything. I obviously don't know everything, you know, because when you're at home, you're experiencing your own, you know, deficits and limitations and pain. And I need that, you know, to educate me. So I think a big part of, you know, the next few years for your students, Dave, in particular, is it's just about finding which path you want to go in and trying to utilize the resources around you and talk to people and, you know, get those connections made to kind of take the next steps. It's really, it seems daunting, but it's a lot more easier.
Oh, she froze up.
People. So we're communicating, you know, daily with, be it athletes, you know, with your peers. I think a big thing is.
Uh-oh. You're freezing up a little bit.
Better?
Yeah, you froze up a little bit.
Oh, okay. So basically, you know, if you have any questions for me outside of this talk, Dave, you have, you know, your students are more than welcome to shoot me an email or anything. So.
Yeah, that'd be great. You know, when COVID is over, we can do observation hours, or we can do, you know, that'd be great. Just for some students coming out and checking out what you do.
That'd be awesome. Down for that too. Like I said, I can talk to a brick wall. So. Oh, I think, are you muted?
So, yeah, no, and I'll fix this. I don't know what's going on with the sound. I apologize how much this is clutching, if everyone can hear this, but thank you so much. This has been great. Appreciate it.
Let me know if you have any questions, guys.
Yep, I will, and I'll let them know. So I may direct a couple students towards you, and then again, after this is over, and you can hopefully open up the clinic a little bit, it'd be great if some students can come do an observation hour or two with you. It'd be great. So, all right. All right. Awesome. Thanks. Yeah. All right. So is this still? Oh, so now it's good. So now that's cut off. There's not a problem. So who knows? I'll figure that out. But that was good. Again, talk to me about this, because we're learning more and more. I am learning more and more about more of the occupational therapy programs throughout. So I know most of you are going into physical therapy, but I think when she's looking into even salary ranges and opportunities. Now, granted, her Athletico clinic, she's got 6 physical therapists and 1 occupational therapist. So in a saturated market, you always have to look at just opportunities in different cities and different areas. I think if you go into a rural area, there are more opportunities, of course, but I think we learned some good things today. So, and again, as soon as we get through this COVID mess, hopefully we can start doing some observation hours in some of these locations and see what they do. So, let me know if you have any other questions. Shoot me emails about any of these. I'm still working on getting a few more people. I am going to try to get another inpatient hospitalist, physical therapist. I have another gym owner and occupational therapist in the next week or two. So, all right. We'll figure out the audio, and it'll be wonderful next week. Otherwise, have a great week. Thanks for hanging out, and always check your inboxes if I send anything out for you guys this week. All right. I'll see you then.